name is Dr. Woods from Inova Fairfax Hospital and here in the emergency department, and today we're going to talk about limited two-point compression for evaluation of the lower extremity for DVT. DVTs remain a frequent source of pulmonary emboli in the United States, and therefore the initial inciting event of a high morbidity mortality event. Even in the case of not propagating for a PE, DVTs can cause lower extremity venous stasis, prolonged tissue damage and subsequent cellulitis, and so appropriate and timely identification of this phenomenon in the emergency department is very important. As many of you know who worked in urgent care and emergency department settings, obtaining an ultrasound for your patient and subsequent results can be a multi-hour process, thus causing a delay in diagnosis for your patient and a flow issue through the emergency department. So what I'm going to talk with you about today is a highly sensitive and specific study that is fairly simple, takes about 5 minutes, and will allow for reasonably effective in-emergency department diagnosis for your patients as long as an appropriate follow-up plan has been made. So I have a high-frequency vascular probe, as you can see here. So sometimes referred to as the vascular probe, the linear probe. This is a high-frequency probe that is going to allow for fine detail in a superficial depth of field. And I have the machine on the venous setting. Venous or arterial setting is sufficient. An important point for obtaining a DVT study is orientation. I have my patient set up here with the affected extremity in a frog-leg position, and the reason for this is because this allows for not only access of the deep and superficial veins, but the popliteal veins, and these are the two sets of vessels that we're going to be examining here. I've got the probe marker noted here on the probe, which corresponds, as I'm facing my patient, to my left shoulder and to the probe marker that you see here. This is an important orientation for you as the scanner because this helps you remember that your left is the machine's left, is left on the patient as you're looking at him or her. So this helps keep everything in line. And the two sets of vessels that we're going to look at are the common femoral vein at the bifurcation of the greater saphenous vein and the popliteal vessels. And what our studies have shown us is that the compressibility of the vessels at these 2 points allows a reasonably high degree of sensitivity and specificity, about a 91% sensitivity, and then close to 95 to 96% specificity when compared to ultrasound tech performed, ultrasound interpreted by a radiologist, and or angiography. We'll talk very briefly at the end about the importance of a follow-up study, given that the sensitivity of the study does remain at 91%. So what I'm going to do is I'm going to go ahead and start at the inguinal crease. One trick that I like to do is either use a sheet or a chuck to just fold under the patient's shorts. If the patient keeps his or her underwear on, this can just keep gel from getting on the patient's clothes and allow access to the inguinal crease. So I'm just going to go ahead and use a little bit of gel here. I've got my probe marker again towards my left, and I'm going to obtain an image here on the screen. And what I always like to do is obtain my image and then do some adjustments. Adjustments of the depth and adjustments of the gain, which is going to affect the brightness of the screen. And what you see here is a couple of things. You've got two hypoechoic or even anechoic, so echo-free structures that you see right here on the screen. So these are vessels that we're looking at here. Now, understand that veins, in their appearance on the screen, can also pulsate just like arteries, and this has to do with the proximity of those vessels to the arteries. So just on appearance, sometimes it can be hard to tell what's the artery and what's the vein. So let's take a minute to remember our anatomy. So as we look at our patient, a lot of a mnemonic that some of us learn is naval. So nerve, artery, vein, empty space, lymphatic system, traveling towards the patient's navel or towards the patient's umbilicus. And what this tells us is that the artery is most lateral and the vein is more medial. From the orientation standpoint we talked about earlier, given that left on the screen is my left as well, this means that the artery is going to be more lateral. So as we look at the structures here, this is what we expect to see, is that this is the common femoral artery and this is the common femoral vein. But let's confirm for ourselves that that's the case. We're going to give this a little bit of compression And when we do that, what we see is that common femoral vein compresses. The common femoral artery does not totally compress and is pulsatile. So this confirms what I remember about anatomy, and this is an important point in ultrasonography. What you see on the screen only makes sense in the context of what you know about anatomy, and anatomical studies and understanding are always at the root of your interpretation and knowledge of ultrasound. So the initial point of beginning your limited two-point compression ultrasound is to start at the inguinal ligament, and landmarks here are the common femoral artery and the common femoral vein at the adjacent section here with the greater saphenous vein. A colleague of mine, Dr. Teresa Liu, is a fan of calling this the snail sign, in that this sort of looks like a snail coming up here, if you can use your imagination a little bit. But the point of this is that this is an important aspect to go proximal enough to not only gain compressibility but establish absence of DVT. And so again, what we're going to do here is just give a gentle compression, keeping in mind that the patient that comes in with the painful swollen lower extremity will have some difficulty with this. It's appropriate to pre-medicate your patient for pain. What I also teach my students is that compression really doesn't need to be any more than a single compress, hold, evaluate, and release. Bouncing up and down on the vein or serial compressions can be uncomfortable for the patient, really isn't necessary. So once we've established compressibility of the common femoral vein at the junction of the greater saphenous vein, what we're going to do is fan the probe in this manner distally, okay? As we do that, we notice a couple of things. One, bifurcation of the common femoral artery, which is here. And let's just show that one more time. Here's the common femoral artery, and here's the superficial and deep femoral artery. Now what you'll notice is that the common femoral vein is still a single vessel but is about to bifurcate. I like to compress at this juncture as well. So I'm going to give a single compression. I see complete collapsibility of the vein, and I'm going to release. All right, what I'm going to continue to do is fan down about 1 centimeter. Okay, so these are small increments. As I do that, I notice two things. The deep femoral artery pretty quickly drops off. Okay, so some depth adjustment is going to be necessary here in just a moment. I'm going to give another compression. I see complete collapsibility of that superficial femoral vein, and what I'm also starting to see is bifurcation as well as the common femoral vein. So I've got the superficial femoral vein and it's bifurcating into the deep femoral vein. Here, I'm going to adjust my depth. Keeping in mind that the focal zone of your ultrasound probe is always going to be right about in the middle of the screen. This is where you're going to get the clearest and most accurate picture. So let's continue to fan down. Superficial femoral vein is here. I'm going to compress. And again, I see complete collapsibility of that superficial femoral vein. And there's a nice little valve that we saw there for just a second. So at this point, let's put some additional gel on our patient. And what I tell my students as I'm scanning is that I like to take a look further down if I can, but you don't have to. This is the point of the limited two-point compression study. Once you've established that at the common femoral vein, at that junction with the greater saphenous vein and the bifurcation compressibility exists, you can actually move on to the popliteal veins, okay? So let's go ahead and do that. At this point, the patient is in a frog-leg position, which is appropriate. If this is uncomfortable for your patient, you can actually have them dangle their leg over the side. You can have them raise their leg up. Whatever is most comfortable for the patient and allows you to place the probe right back in the popliteal space. So we've moved on to the popliteal fossa. Here, what we're establishing is the popliteal artery and the popliteal vein have close proximity to each other. What I'm going to go ahead and do is compress the popliteal vein, and what I see is, again, complete collapsibility of the popliteal vein, while the popliteal artery remains patent and pulsatile. So let's compress one more time. Now, what's important is not only to establish that the popliteal vein is open, but also to fan the probe 1 or 2 centimeters proximally to see the trifurcation of the popliteal vein into the anterior and posterior tibial veins and the perineal vein. There can be a lot of anatomic variation here. Sometimes you'll see small veins that will be offshoots, but generally speaking, the most common anatomic variation is that trifurcation. So let's fan that probe proximally and see if we can see that trifurcation. I'm going to have you watch the popliteal vein here, and we're expecting it to shoot off into the 3 separate veins. So here we've got our popliteal vein, and we're starting to see some superficial branches here. And as we fan our probe proximally, we start to see some of those offshoots here. So anterior and posterior tibial veins and the perineal vein. And again, as I'm looking at this large vein here and the smaller superficial veins, I'm going to keep my probe midline and compress. And I note compressibility of all veins. Complete collapsibility of the veins reliably rules out a large clot. Absence of compressibility is very suggestive, highly suggestive of clot. If there's any question, a comprehensive study should be ordered, and the question of anticoagulation should be investigated.